So hello, and thank you for inviting me to speak for a few minutes today on tuberculosis and corrections and how we can work together. I want to start by saying there is no conflicts of interest in this presentation. For learning objectives, we really want you to walk away with an understanding of the definition of tuberculosis, be able to explain to others how TB is spread, list factors that influence the transmission of tuberculosis, determine if the BCG vaccine is effective in preventing TB infection and disease, and we'll talk about why that's important a little bit. Describe the purpose of case management and verbalize why it's important to work with community partners such as local public health agencies when working with your population groups. So what is tuberculosis? This is something that may be just a review for some of you. Some of you it might be new, but tuberculosis is still around. In fact, we have quite a few cases this year. We're up about 90% from last year at this time. So it's important to recognize that it is still alive and well and causing havoc in the United States and in Colorado. It is an airborne infectious disease, and it's a bacteria. There is no effective vaccine for tuberculosis, but we'll talk about the BCG vaccine in a little bit. Treatable with antibiotics, so it's treatable in its infectious stage as well as just being TB infected. So both are treatable, and ideally we would get people through treatment in their infection stage rather than waiting for them to progress to an infectious disease. It is very serious if it's not treated in time. We're seeing this result in our cases right now due to delayed diagnosis. That's typically when it's not identified promptly and started treatment for TB disease. We'll start to see those more significant issues like wasting away. If you've been in healthcare, you've probably heard that term when talking about tuberculosis. It's wasting away disease. And that's because you lose your appetite, and over time you will lose weight and in fact get to the point of wasting away where you're very thin and your BMI, your body mass index is very low. So that's what you would see in later disease. We hope to catch people early. If we have to have disease, we hope to catch them early before it gets too significant. Because they can die. And unfortunately, we have deaths almost annually due to tuberculosis that is absolutely preventable. Usually it affects the lungs, but it can be found anywhere in the body. So it could be in your blood, your skin, your bones, and your organs, your other organs. So really can be found anywhere in your body, and it is not infectious if it is only in those parts of the body, but if it's in the lungs or a laryngeal area, it is infectious tuberculosis. So when we look at signs and symptoms of tuberculosis, these list the most prevalent that are associated with TB. And if you look at this list, you're going to see a lot of these that may be caused by other things. So lots of people have coughs, especially in the winter and the fall and the early spring, could be associated with numerous other things. But when you have a person who meets the criteria for targeted testing, meaning they are higher risk for TB infection. So this, we'll talk about those risk factors again a little bit, but if you have somebody who matches that, who has risk factors for tuberculosis infection, who now has a cough that's been more than 3 weeks. Perhaps they might say that they wake up at night and they need sheets, especially in the jail setting. Perhaps if an inmate would be asking for a change of sheets because they're all wet, that would be a red flag for me. If they are loss of appetite or weight loss, obviously that's a concern because that's more advanced disease. Hemoptysis is coughing up blood. So when a person has tuberculosis for long enough, they could develop what's called a cavity in their lungs. And that's basically, essentially, a hole in their lung. And when they're coughing up this blood, that's actually parts of that area in the lung that they're coughing up, which is causing that hemoptysis. And again, this could be reflective of numerous other things. So perhaps somebody's spitting up blood, but it's from sinus infections or it's from bronchitis that they've had. It's important to recognize how those risk factors for TB infection are going to help you in your diagnostic process when you're looking at these symptoms. So when you see these symptoms associated with a person of interest who would have risk factors, that's when we would want you to stop and call somebody for assistance, ideally the local public health department, who can help you walk through this process rather quickly. It's not for us to tell you what to do, but it's to help you walk through this more rapidly so that we can get this person through that testing process and you all safe, keep you all safe in the correctional setting. So tuberculosis risk factors, some of them are listed here. And if you see the last bullet point, it's incarcerated individuals. So when you have persons who especially are returning to the jail setting quite frequently due to the behaviors that they're having on the outside, those are persons who have higher risk factors for tuberculosis infection, meaning they have a higher chance of being exposed to someone with infectious TB based on that lifestyle risk. Same with someone experiencing homelessness or substance abuse. Those are all higher risk persons. Now, it's also important to note that they're also a higher risk of being have active disease based on that lifestyle as well. So these are persons you do want to keep in the back of your mind when they're coming through your system, and they have, especially if they have symptoms, that should perk your ears and then get that person referred and get through that testing process right away. Other risk factors to be aware of, obviously, if you're born or foreign travel to places that are endemic for tuberculosis, you're going to have a higher risk of being infected with tuberculosis. So that includes persons who are traveling for more than a month in a country or less if they work in high-risk scenarios in that other country, such as mission trips. So if they're there for a week or two and they are exposed during their mission trip, then yeah, we need to get them treated for TB infection to prevent TB disease from occurring. Medical conditions could increase the risk for progression, much like those lifestyle risks below. Anything that's taxing or working your immune system too hard is going to cause a higher risk for progression to TB disease. Because when you're infected with TB, our bodies are amazing things. They are immediately going to react and try to protect us from TB disease by keeping that TB infection down. So our bodies are constantly 24/7 trying to fight that tuberculosis organism to keep it from waking up, if you will, and causing disease. Once there's another condition or deviation from our immune system, and that includes not getting enough sleep, not eating well enough, like the nutritional value that we're eating, our lifestyle, our comorbidities, such as diabetes. Diabetes alone increases your risk of progression to TB disease threefold. So these are important to know and understand and recognize, especially if you're in a health service unit in your jail setting, to watch for those signs and symptoms of disease and risk factors for TB so that you can focus on those persons. And obviously, if you know somebody that's had contact to someone with infectious disease, would be someone that you'd want to evaluate sooner. Now, they could tell you that they had a contact or they had contact to someone with TB. 9 times out of 10, that means they had contact with somebody who was infected with TB, not someone who has infectious TB, because there's a lot of confusion when it comes to tuberculosis infection versus disease. So I would, if you're having that problem or challenge distinguishing between the two, I would invite you to look at it as similar to HIV and AIDS. Just because you're infected and you have HIV, you're infected, does not mean you're in the AIDS status. AIDS is more of that disease process occurring where it's causing issues. But you could live with HIV all of your life and be well controlled on medications and not progress to that AIDS status. So I hope that helps kind of delineate between the two for TB. There is a link on this, and you should have copies or access to these slides to our Colorado risk assessment tool as well for your use. So when we're looking at testing, the evaluation, screening, and these are basics in TB. We'll get into more specific jail in a little bit. But when we're looking at the medical evaluation, the TB18 form that's listed there, and there's a link to it, is our interview form that we use in local public health departments. And I would encourage you to, and invite you to open it up, look at it, see if you like it. You could utilize it in your facility, or maybe your facilities form, intake form is perfect. You don't need anything. Maybe you just want to add a few things from the TB18 form. It's there for your use. And your guidance. So it's a very helpful tool. It helps me obtain all of the information I need to be able to provide recommendations for the next steps. The tuberculosis skin test is probably the most widely known because it's been around for around 100 years. It's a skin test is where they put protein derivative from tuberculin. It's a tuberculin protein derivative. They put it under your skin and they wait 48 to 72 hours to read it, and they measure a specific bump, which is called an induration. And if you see that picture, that's the injection of the PPD, the protein derivative, into the skin, and it should look like that. It should be more than 6 millimeters big. So if you're getting one and it's not that big, they should really replace it because it's not going to be an accurate test, which is part of the reason why many experts in TB do not trust skin test results any longer, because the quality assurance has essentially gone away with the tuberculin skin test. Many persons who are doing it were never trained properly or thoroughly enough. Temperature is not held, so the handling and storage is not adequate for this solution. People are planting it, calling the injection planting. They inject too deep and they don't get that little blood that you see on the picture here. People don't know how to read the induration. They're reading redness instead of the induration, which is a bump, it's actual bump. They're reading it both directions. That's not correct. They're reading it in centimeters, not millimeters. So my point is that tuberculin skin test is a very good test. I love it, actually, and I think it's a fabulous test if it's done correctly. And the problem is we recognize the quality assurance is not there, the training is not there, it's not adequate, and people are using it but not doing it correctly. So we encourage all to move to that next test, which is an interferon gamma release assay test. And it's typically referred to as IGRA. And I have preferred there because that is preferred. So it's a one-time draw, blood draw, and it takes anywhere from 24 hours to a week usually to get the results. Depends on how many times a week the lab runs this test, but it could be done within 24 hours. The great thing about this is that you only need one visit to get this done. The tuberculin skin test, you need 2 visits. The one to plant it, like you see on the picture, and one to come back in 48 to 72 hours to read that test. So it's a 2-visit to the HSU or health service unit, or whatever you're calling your health service unit in your jail setting. The other nice thing about the quantiferin or T-spot, which are the 2 FDA-approved interferon gamma release assay tests in the United States, is that it's more specific to tuberculosis. The TST, or tuberculin skin test, picks up all mycobacteria. So that's literally over 200 mycobacteria that it could be picking up on. So persons in the United States who have no risk factors whatsoever for tuberculosis, who test positive on a TST, it's likely due to what they call an atypical mycobacteria, which means that it's one of the other hundreds of mycobacteria, not tuberculosis. I'm not saying that they can't be positive for TB, but I'm saying that's typically what is the case. That's typically what we see. So interferon gamma release assay is more specific to TB. It only picks up a few of those other mycobacteria. And it is also, I don't want to say immune, it does not pick up or get an interference from the BCG vaccine. So the BCG vaccine, let me see if that's the next slide, and I think it is. So the BCG vaccine is something that is given in highly endemic countries. It's not given in the United States because we are not endemic, number one. Number two, it is not very effective in preventing TB infection or TB disease. In fact, it does not protect against TB infection or disease at all. And you may ask yourself, why do they give BCG if it's not effective? Because it's effective for something very specific, which is to prevent or lessen the chance of mortality, meaning deaths in pediatric population groups. So prior to the BCG being given, many babies died in the first year of life, first 2 years of life, due to what's called meningeal TB, meaning that TB went to their brain and caused swelling in their lining around their brain, which is significant. And there were a lot of deaths related to this. So the BCG prevents, and it has worked. It has helped prevent these more serious forms of TB that were killing babies and young children. It's not 100%, but it is very effective, which is why they keep giving it. You may have population groups you serve who have gotten the BCG, who are going to tell you that their TST will always be positive because of the BCG, which is not true at all. The closer to birth or the time that it was given, the more likely it is going to give you a false positive on that tuberculin skin test. However, over time, that wanes. That effect wanes over time. So you should have a true positive if you're getting a positive after the age of 18. That being said, the person you are testing is still not going to believe that because they were told all their life that this is going to occur. So that is another reason why we recommend IGRA, the blood test, because that is going to help convince that person who you're testing that this truly is a positive infection, TB, that is not affected by the BCG at all. And we really do need you to consider treatment. Treatment is voluntary. So we really want the person who we're testing to understand the importance of what we're doing, why we're doing it, and their diagnosis. So if they're TB infection, we want them to understand and believe these tests that we're giving them to assure that they're actually going to take the meds if we give them to them. We know that over the decades, many decades of giving medications to persons, that the majority of people do not complete treatment. And many people ask why they take the bottles of medications every month if they're not going to take them. And there's a lot of theories around this. We do not have the exact answer, but there's a theory that I believe to be the case, which is they think that it's mandatory, even though it's voluntary. We want people to know that it's important to take these medications, believe the tests that we're doing, and understand the importance of taking it before they progress to TB disease and potentially infect others with TB. So, other diagnostics for you to consider if you're doing this, and I understand you have time constraints in the jail settings, again, which we'll go over. However, if you are doing the testing, other diagnostics to consider is we really do need an HIV test on everybody. We don't need a new one necessarily unless they have risk factors that would meet that criteria for more frequent testing. So the recommendations from the CDC for HIV testing is once in a lifetime, and then every 6 months if they have more risk factors, lifestyle risk factors for HIV infection. So if we have one on record and we do not have those risk factors, that should be adequate. What we need that for is our diagnostic process and our medications that we can give them. So believe it or not, we do have several, we do this through public health with our population groups we serve. And we found 3 people last year, or at least within the last 12 months, that had newly diagnosed HIV, never knew their status at all. That's important for them to know, for us to know, and it's also going to affect our testing process. So persons with HIV infection, with a lower CD4 count especially, or a lower CD4 count, they may not have the ability, I'm trying to think of a way to explain it in more layman's terms. Their chest x-rays, they may have pulmonary TB, meaning it's in their lungs, but their chest x-rays won't display as a otherwise healthy adult would with a good immune system. So much like young children who don't have a strong immune system, the chest x-rays may have very subtle changes, and it may not jump out like TB to someone who is not familiar with HIV TB infection, but it is TB. So it's very important to know, because if there's any subtle changes on that chest x-ray, we need to be looking at disease. So that's why we need that test on record. It's part of the evaluation process. We are also not able to give the same medications that we can give someone who is not got HIV because of the interactions with the medications. The A1C is a blood test to test for diabetes, and it's a test that looks over the last 3 months of your blood glucose levels in the simplest form I can say it in. So persons who are at risk for diabetes who aren't aware, and I'm guessing that the population groups that you serve in jail settings are similar to what we see in long-term or local public health departments, which are persons who may not have full access to health care. They may not have seen a provider at all. They might not have seen a provider in many years. So they might not know their status, but they still could have it. And it's important for us to know because they have a 3 times higher risk of progression, even higher if that A1C is really elevated to a point where it's causing issues for that patient. So this is a significant risk for us. It also if a person has a high A1C, really elevated, truly elevated, the medications tend to be absorbed at lower therapeutic levels. So that's another reason why we need to know their status. Complete blood count and complete metabolic panels are important for us to know because it can tell us if there is disease brewing or how long that disease has occurred. The microscopy is sputum collection, and that refers to if a person has a positive test, positive TST or IGRA, so that's the tuberculin skin test, or the quantiferin or T-spot is positive. They follow it up with a chest x-ray immediately. This should not be a week or 2 process. This is like, you need to know if this person has disease. So if you get a positive back, they should have a chest x-ray, a medical evaluation, and if there's any abnormalities on that image, or there is any reports, or the healthcare service staff are seeing symptoms, because some people will deny symptoms as they're coughing in your face. So if it's witnessed or reported, you need to get sputum, and that person needs to be isolated in an airborne isolation room. So we'll talk a little bit more about that in a second. So the bronchoscopy and biopsy, I have that on there just because I want to note that we would never recommend going straight to a bronchoscopy, which is where they put a scope down into your lungs, and they usually put some fluid in there and suck that back out, and they test it and they look for TB. They could take a biopsy or a needle biopsy. They could do that too during the bronchoscopy or outside the bronchoscopy. My point is that we don't want to go to that route when there's other things that we can do to diagnose TB disease, because it's an incredibly infectious process, the bronchoscopy. So that is one of the most infectious places you can be, is in a bronchoscopy room with somebody who is having a bronchoscopy who has TB disease, because it's called aerosolized. It's put into the air during that process, and it's all over the place. So we do not want to do that unless we absolutely have to. And this is another reason we want you to partner with your local public health departments. Call us. We can help you through this as soon as possible, the fastest way possible. So imaging. The imaging is just as important as any other step. When you're looking at tuberculosis and you're trying to decipher if this person has TB infection versus TB infectious, TB disease, part of that process is imaging. And you're taking all of these pieces that you're collecting through your interview process, through your sight of this person, through the TST or IGRA, through imaging. All of these are pieces of the puzzle, and no one thing will rule out TB disease. So if you have somebody in front of you who you tested and it was IGRA positive, so the quantiferin came back positive, indicating they have infection, you have symptoms noted, and now you send them for imaging. The imaging, even if it's clear, does not rule out TB, because they could have laryngeal TB, meaning it's in their throat, and they will not see that on a chest x-ray. And I tell you that because we just had a patient like that who reported a slight cough for 2 years, has not changed, was tested for immigration purposes. So they were positive on IGRA. During the interview, reported a long-standing chronic dry cough that has not changed for years. Had a perfectly beautiful, clear chest x-ray, absolutely beautiful, HIV negative, so it wasn't because of that. And we got sputum because that's what you do. They have symptoms or abnormal film, you get sputum. And it was the most infectious you could be. It was laryngeal TB. So this is why you collect all this data, but no one thing is going to rule it out. So you do want to look at the abnormalities. If there's a proven diagnosis, such as a respiratory panel, that the person tested positive for another virus or illness, and that would explain the chest x-ray, that's a little different. You know, you have a positive test confirming another diagnosis. But if there isn't, if they did the respiratory panel, and the respiratory panel, which is a test, a series of tests, if those are all negative and they still have this abnormality and they have those risk factors for TB or a positive test, you really should be thinking about TB and isolating this person. So again, chest x-ray cannot rule it out. I'm just telling you that. Please remember that, because you will hear that. You also want to see the reports, the radiology reports. Do not rely on verbal report alone. Look at that report. And I understand that some may have contracted radiology groups or such, but you do need to look at that report, because I can't tell you how often I've been told that a chest x-ray is normal when I got that report, it was not normal. It actually had abnormalities, but they said it didn't look like TB, and you cannot rule out TB by the chest x-ray. So I just want to hit that home. Okay, and because it's a reportable disease, it is in the legislation or code of regulation that it is reportable to the health department, either the local or the state health department, and that would be us. If you're calling the state TB program, it would be us, or the local public health department where the patient resides is preferred. However, we understand that it may be a barrier for you to find that, so just call your local and they'll call us and we can figure that out. This is within 1 working day. So if you're working someone up and you're starting to see this puzzle piece come together, if you will, call us. Don't wait for a diagnostic test to prove that they have it, because again, no one test is going to rule it out, and we have to look at that bigger picture and protect that patient and the community. So remember to call local public health or state within 1 working day. One second. So I wanted to add these slides regarding who to call, because that's often the most challenging piece of it, is trying to figure out who is the local public health department and their contact information. So this slide is really here for your reference. You can find your public health department by clicking on that. The state TB program, we have a link to the contacts in our program and what we all do. So if you're looking for data, you'll see the data coordinator. If you're looking for policies, you could call our state TB program manager. If you're looking for recommendations or to talk through a case, you'd call me, but those are all listed there. What things I'm going to ask you, especially if it's patient specific, are those things. So the interview form, whether that be your form or the TB18 form I referenced earlier, the IGRA, which again is the quantiferon or T-spot, or TST, tuberculin skin test results, chest x-ray report, and the HIV test result. Those are going to be the minimum things that I need from you to move forward. But I'm probably going to ask for some more information because we want to make sure that we're rolling out somebody quickly. So I'm going to share some poll questions with you. If you give me 1 second. There's going to be 2. Hope I'm doing this right, so bear with me. 2 questions. So the first one is, does your facility have at least 1 airborne isolation room, which is a negative pressure room in a cell? And if you can answer yes or no, that'd be great. We're going to wait for a few more responses. And I see the second question. People are already on it. Do you know how to use a negative pressure room if you needed it? And I'm going to ask Sydney if you could please just take a screenshot so I can come back to these. So it does look like there are some facilities with the negative pressure rooms, which is fabulous. If you do not, and you have a person that you need to work through, you may have to move that person to a facility that does. I believe Denver Health has a jail attached to it, I've heard, that has a couple negative pressure room cells. So if that's what we need to do, that's what we need to do to move a person. Otherwise, I have seen people admit them to the hospital to get ruled out. Ideally, we do it in a setting that has that capability to protect the patient and the staff. if you have a negative pressure room and you don't know how to use it, please do not wait until you do need to know. Please find out. Talk to your, especially if you're in a health service unit of some sort, talk to the environmental staff that you have in the jail setting, your supervisors. Make sure that you have a policy in place that not only do you know how to use it, but how do you care for it? How do you test it? Because many facilities aren't doing the testing to make sure that it is working. And there are times when you need it and you go to turn that on and it's not even working, and you're not knowing that it doesn't work because the quality checks were not done. So please check in to your policy procedure internally, make sure that there is one. If not, and you want to do one or put one together and you need a template, I'm sure I can find templates for that. You could just contact us and we can try to get that for you. Okay. So key components to infection control. On my screen. So because it's airborne, so it's spread through the air, of persons who talk, sing, cough, anything that is projecting that out of our lungs, breathing, is putting that in the air. So we want to make sure that staff are protected and that the patient is in a negative pressure room, as we just discussed. One thing I want to talk about is the difference between the masks. So I often hear of patients getting the N95, which is a respirator that's more tightly fitted. You need fit testing to wear an N95. It is a small particulate filter, basically. And if you were paying attention to COVID, you saw people were talking about surgical masks versus N95s, which are the more form-fitting face masks. That does require fit testing before you start using it to determine which masks fit your face, as well as annually, and that is an OSHA requirement. More often, more frequently for those persons who have facial structure changes. You cannot wear an N95. So for example, if somebody lost weight, if you lost weight in the last year, you should have a new one because it's probably not the same fit. And you need a tight fit. It seals around your face. So the other thing with N95 is you can't have beard or facial hair around that area because it will impede that tight fit. Capper and PAPR are the air purifiers. One's a positive pressure, and I can't remember what the C is for the capper, but it's a similar concept. They're two different set of equipment that works very similarly. So it's those hoods that people wear, and it's a mask that comes down and it has positive pressure. So it's constantly pushing air out so that the person's infectious air that they just exhaled is not coming in your mask. It's pushing that out. If you have a capper or PAPR, and if you don't know, ask. If you have one, ask for the policy or the procedure of handling and storage of that. I did work in corrections and maximum security settings, a little different than the jail setting, but similar concept. So I was their infection control person. I had to go review all of this. There was no policy for this. I found their PAPR underneath the sink, and it was filled with mold, and it was pretty horrific. So we bought new PAPRs. We trained the staff on how to use those PAPRs, how to put them together, how to store them, how to clean them in between use, where they're going to be stored. Did a policy for it, and that was great. Everybody knew, everybody felt comfortable. They didn't have to wait until they needed it to get that training. I highly encourage you, look to see if you have them, see if there's a policy. Make sure if you have N95s, the masks, that you are getting fit tested annually, that it is a good fit, This is important. This is protecting you. Patients do not get these masks. You don't want to put an N95 on a person who has respiratory illness. If you've worn one in the last 3 years during COVID, you know how hard it is to breathe in those and how uncomfortable those are. Now add lung issues or lung disease with that. It's a dangerous situation. Surgical masks are required for the patient with limited movement within the facility, and that's only if they have to. Negative pressure room, obviously, we just talked about that, and making sure your negative pressure room is working up to par. And TB is not spread through saliva, through plates, through silverware, cups, surfaces, or laundry. That's often what I've seen in settings that aren't very familiar with TB. They panic, they put this contact, and outside of the airborne infectious, they also put a contact in isolation room up or notice up. So they have all of they serve them with plastic silverware and paper plates and separate their laundry. This is not necessary. It's overboard, and it's also adds to the stigma and the fear behind it in the correctional setting. It just causes more panic. So please know it's not spread through those. Be assured it's not. It's airborne. So you do not need to separate all these things or feed them with plastic utensils and paper plates. So treatment, I'm not going to go over this too deeply. The point is that the decision to test is a decision to treat. We are testing in these correctional settings because they're high-risk population groups, and it's a communal, it's a congregate setting. They're all in place. So we want to protect the other people who are being exposed. That's why you're doing this. You have a high-risk group, and you have a close setting where they could expose each other. That being said, we understand that jail settings, they're there for a short amount of time, so you're not going to get them through typically treatment for tuberculosis. However, it would behoove you to do this test ASAP so that we know the person's status, understanding that many of your residents, if you will, return. So knowing their status is really important. If you have this person who's continually coming back and you know that they're infected and never got treatment, you're going to be constantly looking for TB disease. Now, if you have a person who you tested who is positive and you referred that person to the local public health department and had a close relationship to communicate this back and forth, you will have that on his record when he or she, when they come back, that the person completed treatment for TB infection, which is going to help you grossly. So you want to consider all of these things when you're talking about starting treatment. You can start treatment. Some persons are there long enough to complete treatment if you get through the process in time. I understand that you're under a lot of constraints. So I'll just say that it is possible, but I understand your constraints in that setting. Standard treatments, again, I'm not going to go into this too deeply. I just wanted you to note that these are the current recommendations for treatment of TB infection. And we want to do that, and we want to treat them with TB infection because there's a lot less drugs, a lot less burden. Obviously, they're not infectious, so we want to treat them during the infection stage, not infection stage. We're going to do another poll. If you give me just 1 second. Let me see. Okay. So does your facility or look? Okay. I'm not going to wait too much longer. I know there's a lot more of you here, but for those who are unsure, please find out, please ask the questions. We would encourage you to include in this plan, if it is something like this, tuberculosis infection or disease, that you have something specifically stating that and working with your local public health departments in that plan. We did include samples of things that you could use in the resource list. So I'd invite you to take a look at those. Okay, so let me move on because we're getting close to the time and I want to allow some time for questions. So when we're talking about breaking the wall, we're talking about that barrier that we know at least existed before COVID. I can say, having worked in corrections, I can appreciate the time constraints and the monetary constraints and the situational constraints that some of you are facing. Even though I was in a maximum security prison, in an infirmary and in an HSU, that is not the same as a jail setting. I understand that. I understand that you are facing sometimes much more challenging situations, such as persons who are having an acute mental health crisis, or perhaps substance abuse issues that they may be coming in with that they need to detox. And we understand that you are often forced to deal with those issues. So we do get that, and we do get why there's that breakdown in communication sometimes with even the process of release. Sometimes health service units aren't aware of the person being released before they're released. These are all discussions we would like you to have internally, and include your local public health departments. We're here to help you. We're not here to make more work at all. I can speak at least for myself. I guarantee you I'm going to help you make it easier if I can, because we get the challenges, but we do need it done, because this is where we're finding the TB cases, at jail settings when they're coming in. Not when they're going to prison, because they've already been through the process of the jail. So typically we don't find them on intake in the prison setting. We find them in intake in the jail setting. We know this. This is what our data is showing us. So please be aware of that, as well as the rise in our cases. So we would like to help you. We would like to partner with you. We would like to have that communication upon release, so that if a person's positive, we can follow up with them upon release right away. Sometimes those local public health departments can get there before they're released, to start those conversations with the inmates before they are even released, which is great, because that continuity of care is there. The patient starts building the rapport, or they start building rapport, reduces risk to the community and poor patient outcomes. So if we work together, we can certainly get that done. So again, having worked in corrections, I get the time constraints and even the monetary constraints with the budget, including the changeover of contracted agencies, healthcare agencies. I do recognize the challenges that you're facing, and I appreciate all of you who are working in corrections, because it takes special people, strong, brave people to continue to work in corrections. So I thank you from the bottom of my heart for continuing to work in corrections. That said, all of this is extremely, I would not be asking you to add more to your plate if it wasn't important. We need you to test the persons, especially if you're seeing respiratory illness, through your interactions with clients in your institution. Is there enough time to get somebody through testing? That's often what I hear. Well, we can't get them through the testing process because it takes a week or two for us to even get the test done. Someone should be looking at that person day one, because you now have 2 weeks of people being exposed. Someone should be interviewing that person and looking at the TB risk on day one. You might not have to test day one if this person appears totally well, even though it's recommended. I get it. But if there's respiratory symptoms and this person doesn't look well, and this person has risk factors for TB, which automatically 100% of your population does, you should be isolating that person and looking at that person and getting them through the testing process sooner. Obviously, that's going to help when they come back. And again, if we can get them through treatment through the local public health department, if you can see where I'm starting to paint this picture of, if you get the testing done and you refer to public health, perhaps we can get them through treatment before they come back to you. Perhaps we can even prevent them from coming back to you through our interactions. I'm not saying that's possible at all, just saying it's also possible slightly that it could occur. And then we understand, again, those challenging situations and that those take precedence over TB infection. The only time TB disease or TB would take precedence is if there's concern for TB disease, but even these are more acute needs than TB disease. Obviously, we understand the challenges that you're going through, so we do not want to add to that. And we get the employee turnover. We're facing that everywhere, and the contracted medical services changing when that time comes. So we just want to help you make this as easy as possible, prevent TB disease in your facility, prevent the transmission of TB disease in your facility, protect your staff. That's what public health is here for. So please utilize us. So in conclusion, tuberculosis has not been eradicated despite popular belief. It's extremely complex airborne infectious disease, but that's why we're here to help. And public health calls me every day. So it's not just public health that knows. I'm a specific TB nurse. That's what my role is, and it's 100% TB. So we'll get you through this as fast as we can. People who are incarcerated are at high risk for TB infection and disease. Prompt screening is essential to control it. Infection control policies are necessary components of TB control and should be not only written, but practiced, reviewed, and followed. And then obviously consult. If there's any doubt, consult. We are here to help you. We want to help you through this. And in that, I'm just going to give you these references, and I did not allow too much time for questions, but I'm happy to answer whatever you have.
Okay, if there are any questions for Anne, please either raise your hand or put them in the chat function so we can get to them as we have time. And if there are no questions now, you can feel free to submit the questions to Anne directly or to me here at CSOC, and I'll pass them along to the Department of Public Health so they can answer those questions and get back to you to get you all the information that you need.
Really appreciate the opportunity to present today. And again, I can't tell you enough how much I appreciate all of you in corrections. Truly are a special bunch.
All right, I don't see any questions so far, Anne. So what I'll do is if I have any come in, I'll forward them along through everything to you. I appreciate your time today. I appreciate everyone's time today. Thank you for attending the first of several webinars coming up we have with the Department of Public Health regarding all these wonderful topics for corrections-based health services. So thank you all very much for your time, and we'll go ahead and stop the recording now and have a wonderful day. Oh, wait, one more second. We have one poll results with, let's see here. Okay, I'll just handle that one. That's for me. That was direct.
Okay.
So yes, I'll share the poll results with you as we go forward. Let's see if there's something else. Perfect. You all have a great day. Thank you so much. And we'll go ahead and stop the recording now. Thank you for coming.